medical problems. Prior experience and expectations affect how people interpret symptoms. What happened to me over the weekend? Oh, I was running this weekend. I did something stupid. The first time I was ever on that trail. There's a thing that goes up. I don't know. It's about 10 feet tall, and you have to run up this thing. It's angled. Well, I did it, thinking, oh, I can do it. And of course, I popped something in my heel. And now I've got plantar fasciitis. Anyway, yeah. So the question is, so when did I start doing something about my plantar fasciitis? Very painful. It is not. Anyway. So I've got plantar fasciitis. So when did I start doing something about it? The answer is, I just did something about it. I've had it for like 4 weeks, and now I finally did something about it. I wasn't exactly sure what it was. My daughter popped her, she ruptured her Achilles tendon and had to have surgery. Could have been that. Could have been and actually it's a preliminary injury for ruptured Achilles tendon. I've had Achilles tendonitis before. Had all kinds of interesting problems with my left foot, not my right foot. Anyway, so when did I do something about it? I did something about it like about 3 hours ago. I got online and I got a cup. It's a heel cup, and you put it in your shoe. I used to wear one when I was a long jumper. And if I'm too short to be a long jumper, that's what they said too. Anyway, best jump 22 feet 2 inches. All those 2 inches. Just in case you're I know. Some patients have a tendency to exaggerate expected symptoms while ignoring unexpected symptoms. And of course, those kinds of things happen all the time. Rubble in 1972 found that women who were led to believe that their menstrual periods were imminent reported more symptoms than did those who were led to believe their periods were not due for several more days. I don't know how important that is. 1972, that was 50 years ago, wasn't it? So that piece of research is 50 years old. Is it still true today? Well, I don't know. It's in your book. Evidently, Straub thinks it's still important. There are differences between men and women, lots of differences besides long hair. Of course, that's not even a difference anymore. Women are more likely than men to report symptoms and use health services. Women may be exposed to more illnesses than men are because women tend to be around their children more, and children bring home diseases from school. Women may be more sensitive to their internal bodily symptoms than are men, mainly because you are trying to determine when your period is going to start. So you're thinking about your internal structure far more than men are. Men don't think about it at all, maybe never. Somebody stole all the chairs. Actually, this table was huge. Oh, there's a chair over there. So that's not bad. Or you can have this chair, this really nice chair. Or you can have that chair. You can have any chair you want. I'm kind of into rolling, so I'd take a chair that rolls. Social factors such as the fragmented nature of healthcare for women may be factors, and of course this has been a problem. We have done a lot of research. Most of the research has been on men and their medical problems. As it turns out, men have more medical problems than women do. Women complain more about their medical problems than men do. Over one third of men would not go to the doctor immediately, even experiencing chest pain or shortness of breath. And of course, my own story supports that. I had a heart attack the day before I went in to see the doctor. And the only reason I went in to see the doctor is because I couldn't sleep that night. Every time I laid down, my chest hurt and I couldn't breathe very well. So that's why I went to the doctor the next day. I only had 97% occlusion in my heart. Only 32% had been checked for cancer, mostly prostate cancer in the past year. The way you check for prostate cancer is you draw blood. It's fairly simple. But only 1/3 of men have had their prostates checked. Men were less likely than women to report having unmet medical needs, and it's mainly because men are stupid. Did I say that? Okay. Thank you. Did you do something?
Yeah, the boss is making some adjustments.
Okay. Whatever. Thank you. You kind of like the sauna. Let's vote. How many people like the sauna? Pretty much asleep. Okay, that's perfect. People with high socioeconomic status generally report fewer symptoms and better health than do people of low socioeconomic status, mainly because they eat better and they exercise more. They've got more leisure time. They've got more free time to exercise. When they are sick, however, high socioeconomic status people are more likely to seek health care, mainly because they have money and they can do it. I have had free health care all my life. Wait a minute, that's not true. I've had free health care ever since I was graduated from college. As soon as I joined the military, I had free health care for the rest of my life. I know. Now I'm so old. How old are you? I'm so old I get Medicare. So I not only have TRICARE, I also have Medicare. And this institution actually gives me insurance, which is kind of fun. Low socioeconomic status people are overrepresented among those who are hospitalized, mainly because they don't go to the hospital until they're dying. And because of that, they're hospitalized more frequently. Because they don't take care of themselves before it gets really, really, really serious. Some cultures encourage a strong reaction to symptoms, while others socialize members to deny pain and keep symptoms to themselves. A lay referral system is an informal network of family, friends, and others who offer their own experiences and advice regarding symptoms, and you can find this crap on the internet anytime you want. Oh, that's my bottle. Okay. Seeking timely care when symptoms arise can mean the difference between dying and catching a disease when it is still treatable. Delay behavior is the tendency to avoid seeking medical care. There are 5 delay stages. We're not going to talk about all 5 of them. The last 3 have to do with the last 3 stages delay longest for patients who were more concerned about cost of treatment, had little pain, and were doubtful that symptoms could be cured. So if you think you've got something that medical care isn't going to be able to treat, like a cancer, then potentially you'll just not seek any medical care. Or if you're afraid of cost, you won't seek any medical care. I'm signing everybody in for or if you're afraid of the cost. A lot of people are afraid of the cost. My wife gives me a hard time about these kinds of things. Even though I get free medical care, it doesn't make any sense to me. One of the problems is that we have insurance from this institution. And because we have insurance from this institution, they do a really crappy job. Okay. All the medical treatment I had last year, they just paid it like 2 weeks ago. We tried to explain to everybody, well, they're on the same schedule as IHS. And IHS gets their funding like once a year. And then they have money for like 3 months, and then it's all gone. And then they're treating you with, I don't know, rocks and sticks, I guess, or something. They spend all their money almost right away. So if you want good medical care, or if you want medical care, actually they're probably a couple of years behind. And if I understand correctly, the last Congress wanted to cut IHS funding. So yeah, and Trump doesn't care. He doesn't like you guys. No offense to, well, no offense to you guys, of course. I guess that's almost a compliment. He doesn't like you. Anyway, so that can potentially be a problem. Illness, anxiety disorder, what we used to call hypochondriasis, is a condition of experiencing abnormal anxiety over one's health, often including vague, ambiguous, or imaginary symptoms. And of course, Sheldon is a perfect example of that. If you watch Big Bang Theory, he always thinks he's sick, or if somebody is sick, he wants to get them away from him. Malingering, of course, is something that we used to see in the military all the time. As a medic, I was given the opportunity to see this on a frequent basis. This is somebody that doesn't want to do something, so they pretend that they're sick. I don't know if you ever did this, but I did this when I had a spelling test. I caught the flu that day, or a sore throat, or a cold, or something. I missed a lot of spelling tests when I was a kid, and now I can't spell. I guess, or maybe I couldn't spell, and that's why I didn't want to take the spelling test. Anyway, chronic fatigue syndrome is a disorder of uncertain causes in which headaches, infections of unknown origins, extreme tiredness, and difficulties with concentration occur. I have a friend who's actually a college professor, very, very popular man. I swear the guy's got Asperger's syndrome, but we won't go into the Asperger's syndrome. Right? Really interesting fellow, really attractive. I think I told you the story that he had an affair with my first wife. Didn't I tell you that? Anyway, he had an affair with my first wife. Probably didn't realize what he was doing. I mean, that's how stupid the guy is, and how smart he is. But he has chronic fatigue syndrome, and his daughter has chronic fatigue syndrome, as strange as that is. Now, the bizarre part about the whole deal is that somehow she got pregnant, and we're not exactly sure how that happened. That's really none of my business, and I don't really care. But she got pregnant and had a baby. Well, she has chronic fatigue syndrome, so through the pregnancy she would run out of energy and she couldn't get out of bed. It was one of those kind of deals. So finally she has the baby, and of course, as somebody with chronic fatigue syndrome, she can't take care of the baby because she's just too tired, like all the time. So the mother and the father were taking care of the baby. Well, the father's got chronic fatigue syndrome as well. So it was really kind of a toss-up as to what was going to happen next. Well, guess what did happen next? So we've got a lady with chronic fatigue syndrome, and she has a baby. Her father's got chronic fatigue syndrome, and so the grandmother and the grandfather are taking care of the baby. Guess what happened next?
The baby has
No. It's a baby, my God. The problem is the baby crawls along the ground, nobody can catch it. He was actually a miler. I ran track with him in college. He was really good. He was a miler, went to nationals. He had a problem back then too. He had a problem practicing, hated practicing. Anyway, so guess what happened? The baby doesn't have chronic fatigue syndrome. Baby's okay. So guess what happened next? These are white people. Oh, I didn't tell you they're white. I'm sorry. These are white people. Guess what happened next? See what you guys think of white people. I'm sorry?
Is that they call the cops?
Call the cops now. On who? First they put the baby up for adoption. Well, who's going to take care of it? The mother? The grandmother? My God. My grandmother's going to take care of babies. What's wrong with you guys? What's wrong with you guys? Anyway, they put the baby up for adoption. I was pissed. I was pissed. I thought that was the laziest thing in the whole wide world to do, is put the baby up for adoption. How old was I? 23, 24. I had 2 kids. My wife left me. And I took care of the kids. It's not like I called grandma to come in and take care of the kids. I took care of them by myself, and I was in the service at the time. So I was on duty 24/7. You know how the military is. Not really. I mean, they'd call me out at all times of the night. I took care of the baby, and there's 3 of them to take care of that kid, and they can't do it. What a bunch of lazy pieces of crap. Anyway, he's a college professor. I teach 5 classes every semester. Actually, I'm teaching 7 this semester. Guess how many he teaches every semester?
2.
He teaches 3 in a year. He teaches 3 classes in a year. 3 classes, and I teach 7 every semester. What a lazy piece of crap. Anyway, and he couldn't take care of that baby. And she couldn't take care of that baby because she's a blonde, skinny blonde lady. I was so pissed. Anyway, that's what happened. Chronic fatigue syndrome. There are no diagnostic tests for chronic fatigue syndrome. There are things that we can treat it with. Fibromyalgia can be part of this as well. CFS and low blood pressure, persistent viral infections and immune system dysfunction in some individuals. There are varied time courses and recovery patterns. He has no problem. He hikes out into the wilderness. He lives in Montana. He teaches at the University of Montana. So he hikes out into the wilderness every year. He can do that, but he can't take care of a baby on a daily basis. I don't know who raised the first kid. They only had one daughter. Anyway, she got pregnant by a boyfriend, who was a live-in boyfriend until he found out she was pregnant, and all of a sudden he disappeared. There's a shock for you. Treatment, cognitive behavioral therapy can increase the tolerance of symptoms and modify maladaptive illness beliefs. They use a multifactorial approach. It seems like everybody is different. If you've never known anybody with chronic fatigue syndrome, we used to not believe it. We thought it was malingering. We used to call it malingering. I know, it's sad, isn't it? And now they have suddenly decided this is actually a disease. Some of these individuals suffer from mononucleosis chronically. They can't get rid of it. But others, we can find no reason for them to have chronic fatigue syndrome. Adherence is a patient's willingness to allow prescribed treatment regimen. That's adherence to what the doctor tells you to do. As I told you before, my wife is having surgery over the summer. Not one hip, but both hips are going to be replaced. So they're going to put her on some kind of rehab. She has a rehabilitation plan that she's going to have to go through. And in order, this is the way it works. If I don't show up at the beginning of next semester, there's a reason for it, okay? If she has any problems, I may not be able to come back down here. But as long as everything follows the plan that it's supposed to follow, then there should be no trouble. It should take about 5 to 6 weeks for her to rehab. She has to, they're not going to do both hips at the same time. That's too debilitating, so they're going to do one hip and then they're going to do the second hip. So they'll do the first hip at the end of May, and the second hip they'll do at the beginning of July, I think. And that should maybe, I hope, give us enough time to get everything done. By the time she has the second hip done, we'll have everything down pat and we'll understand what's going on. Does it feel like it's cooling off in here? Or?
Yeah.
Okay, good. Anyway, so that's adherence. So, but she has to adhere. My wife notoriously hates doctors. Not as bad as I do, but she does hate doctors. She was also a medic, and she worked with them for years. She babysat them because they act like big babies almost all the time, anytime. Anyway, so adherence is going to be a question. Non-adherence is a patient's refusal to adhere to or lack of sustained effort in following a treatment regimen, and that's non-adherence. In most cases, if you are non-adherent, if the doctor finds out you haven't been doing what he's been telling you to do, he can fire you. He can get rid of you. He can kick you out of his practice. He doesn't have to treat you if you're not adhering to what he tells you to do. Of course, most doctors don't do this because you mean money to him, so that normally doesn't happen. The rate of non-adherence is about 25%. There's a shock for you. 25% of the time the doctor tells you to do something and people don't do it. I had orthoscopic surgery on my left knee. I had 2 tears and a buckled meniscus. And then when he was in there, he found out that my ACL was detached. So here he does all this stuff to my knee, and he didn't give me anything to do. He didn't give me any rehab. And I figured, well, what the hell? I must be okay. I must be fine. So I go out and I start playing softball almost immediately. And then that was the more. And unfortunately, since I didn't have an ACL, he trimmed whatever was left in there. since I didn't have an ACL, my knee actually bends back, which hurts like the devil. As you can imagine, it hurts like the devil. So here I am trying to play softball, and of course it didn't work. So I went back to him and I said, well, why didn't you tell me I needed a brace or something? And he said, well, it was in Montana. He said, well, old farts like you, we don't even tell them anything because we know you won't do it anyway. So non-adherence 25%. I guess for old farts it's closer to 100%. Anyway, so he didn't give me a brace, he didn't give me anything, didn't rehab me. I just went out and started playing softball, and I had a hard time running. I'll tell you, it was hard. Especially stopping and, planting and pivoting. Yeah, pivoting was almost impossible in my left leg. 20 to 40% of participants in smoking, alcohol, and drug abuse treatment programs continue treatment compliance after 1 year, which means over half of them are non-compliant as far as drug, alcohol, and tobacco are concerned. Obesity treatment program attendance drops after 3 to 4 months, and there's a shock for you right there. Patient variables, what makes people more adherent or less adherent? Gender is huge. Ethnicity. A lot of individuals, well, let's take IHS for example. You guys get to go to IHS. How much do you think people listen to what the doctors are telling you? For one thing, most of the doctors are not non-native. I don't know if you noticed that or not. Most of them are white people probably. Some of them may come from India or last time I went into the emergency room in Iowa, I had an African guy that was my doctor. He was funny. He was funny. He looked like he was pregnant. I think it was a guy. No, it was a guy. But he had this huge pot belly. And he wouldn't touch me. It was really kind of bizarre. I had a pain in my side, and instead of palpating my abdomen, he just kind of said, here, touch over here. What does it feel like? It was like a gut, I guess. What do you expect? He got upset because I told him that opiates don't work, and I don't know what he thought I was looking for. I mean, there is nothing stronger than opiates, so what the hell did you think I was trying to get out of him? I don't know, gold or something? Anyway. Gender, ethnicity, education, and income are poor predictors of adherence. Having the support of family and friends, being in a good mood, and having optimistic expectations promotes compliance. So the happier you are, the more likely that you will adhere to what's going on. Providers' display of empathy and confidence is big. When I first started in medicine, they weren't training doctors at all as far as bedside manner was concerned. Some doctors were nice, some doctors were not nice. Some doctors acted like House, if you've ever seen the movie or television show House. Hate that show. I won't even watch it because I've worked for doctors that were worse than him. So, and House is pretty much a jerk. Isn't he a jerk? Isn't that the whole point of the story? Provider variables, whether the doctor likes where he's working or not. Potentially you have run into these IHS doctors that hated where they were, hated working on the Indian reservation, hated working in the desert. They're from Maine or something and they don't want to be here. We ran into that a lot in the military. My first permanent duty station was Lubbock, Texas, and you can imagine how much everybody hated Lubbock, Texas. There was something going on in Lubbock, Texas. Every child that arrived in Lubbock got diarrhea, and they maintained the diarrhea until they left. And we couldn't figure anything out. We had no idea what was going on. It was just diarrhea. And, every bowel movement was a diarrhea. Bowel movement. We would collect specimens on everybody, on all the kids in the. On base, and we found nothing, absolutely nothing. For a while we thought it was an amoeba, then we thought it was a virus, and we had everybody checked. We looked for bacteria, we found nothing. All we found was a lot of diarrhea, a lot of squirts, unfortunately, strangely enough. So a lot of people didn't like Lubbock, Texas. I don't know if you've ever been there. It's the Llano Estacado. It was such a nasty place that Even the Indians that lived in the area wouldn't go up there. They used it as a race course. That's all they used it for. They didn't live up there. Up on the Llano Estacado, it was the Comanches that lived in that area, and they're the ones that named it the Llano Estacado. Anyway, they hated it. So there was very little job satisfaction in Lubbock, Texas. The number of patients that they see every week, if they see too many patients, of course, it makes them unhappy. If they have a good communication style, and if they have patients that will adhere to what they say. A lot of times, patients will not believe their doctors or hate their doctors or whatever. Treatment regimen variables, keeping regimens as simple and short in duration as possible. Tailoring treatment to fit the patient's lifestyle, and that's always important if you're living in a place like Montana where people do whatever the hell they want to do anyway, so you try to tailor it for people that won't do what you tell them to do. Simple, understandable instructions, the simpler the better. Involving family members as much as possible, friends and others in the patient's treatment. Usually it's a family member. If it's a husband and wife situation, then usually you won't be able to get the husband to do what you tell him to do. You have to tell the wife to make the husband do these things. And then sometimes it works. Providing feedback about progress, of course, that is important as far as adherence is concerned as well. Factors affecting patient-provider relationships, the continuity of care. I guess this is a really serious problem, especially a serious problem in the military, but it's also a very serious problem at IHS. If you go over there, what's the probability you'll see the same doctor over and over again? Is it 0 or 3%, 9%? What's the probability? For a while they tried to do this, actually, in the military. They tried, when they first started the HMO and PPO programs around the United States, they tried to do that. They tried to get a doctor for a select group of individuals. The problem was that military people get sick whenever they get sick, not when the doctor is working. So that was a problem. That was a really serious problem. That and the fact that they would go to the emergency room a lot. And since you never knew who they were going to see at the emergency room, it just didn't work. So continuity of care is really important. In Iowa, I do have a doctor, and in order for me to go see anybody, I have to go see my doctor first. Well, he knows I don't like him. So we have this antagonistic relationship. And it's kind of a cool one because he actually fixed me the last time I went in there. I had vertigo. And he told me how to fix it, and it worked. So I've got new respect for him. Not very much, but about this much. So then I'll go in and see him again. He also took a tumor off my forehead, and he did a really good job. He was a plastic surgeon before he became a general practitioner. Really kind of interesting. So their communication style is really important. I worked for a doctor in Oklahoma who had his patients just loved it because of his communication style. He would sit down and talk to them. And he was a DO, so he did a lot of holistic medicine. Anyway, his communication style was really, really good for his patients, but he was just a jerk when it came to the people that worked for him. You could never do anything right, which was kind of exciting. Overall quality of consultation, of course, is also important. Patient-provider communication is the backbone of all medical treatment. A lot of doctors don't believe this, but it is true. 60 to 80% of treatment decisions are based on information that arises from the medical consultation process. And this can be a problem. Sometimes getting information out of a patient is like pulling teeth, literally. You have to force them to give you the information. You have to ask them the question before they will tell you. How do you feel is not a good question. It seems like it should be a good question because then they'll tell you how they feel. But that isn't always what happens, especially if we're dealing with somebody who's diabetic. One of the problems with people with diabetes is that they have circulatory problems. And if somebody comes in, they need to check their feet every time they come in because their feet will go numb. They may have sores on their feet or on their ankles that need to be taken care of. And they may not complain about it because it doesn't hurt. And if it doesn't hurt, of course, they're not going to say anything about it, unfortunately. So the doctor needs to check their feet every time they come in if somebody's diabetic. He needs to check all their extremities. He needs to check their fingernails. He needs to check their hands. But especially he needs them to take their shoes off so that he can see their feet. Well, some people are really, really sensitive about their feet for some ungodly reason. I have no idea. You know, some odd white person taboo about showing people your ugly, knuckly feet, I guess. Anyway, I'll show people my feet all day long. You want to see them? It doesn't matter to me. I like my feet. I think they're pretty. But nobody gets to see them but me. Nobody wants to look at anybody's feet. A provider's communication style is the most important factor in a patient's satisfaction with his or her doctor. Provider's communication skills, including nonverbal behavior, is quite important as far as that is concerned. A lot of times doctors are very harried. They have a life to live as well. This is a job for them. They want to be your best friend or whatever friend they can be, but sometimes it just doesn't work out that way. Patients often leave a consultation dissatisfied because of a lack of information, poor understanding of medical advice, and the perception of being unable to comply with treatment instructions. And this is one of the things that you need to relay to your doctor is how much medical knowledge you actually have. That way they will know how to talk to you. And of course all doctors, especially with the HMO and the PPO situation, not so much with Obamacare, with the ACA, but the way they did it before, the more patients you saw, the more money you made. It was just that way. They also gave you bonuses for the fewer people that you actually treated with expensive drugs. If it cost them too much money, if the insurance company wanted you to not treat people. They wanted as little treatment as possible. So if you could save them money, because they didn't have to pay out any insurance, if you could save them money, then they'd give you a bonus. I know, that seems upside down and backwards, but that's the way it worked. And it's one of the reasons why they wrote the Affordable Care Act, they were trying to get the HMOs and PPOs to comply to good medical practice. And of course it wasn't working before. The more time physicians spend with patients, the more satisfied the patients are. Of course, each patient represents money as far as the doctor is concerned, especially if he is an HMO or a PPO. Then the more patients he sees, the more money he makes. Unfortunately, of course, and this is one of the sad things about medicine, a lot of people are in medicine for the money. They just want to make a lot of money. And you can make tons and tons of money. You don't have to treat anybody. You can just be there and look at people and tell them they've got a cold and go home and take an aspirin. And we're not going to give you a prescription for the aspirin because then that would cost my insurance company too much money. So go home and buy your own damn aspirin or ibuprofen or talk. I don't know. And that way I save money and everybody's happy. Unfortunately. That's the way it was when the insurance companies were running medical care. The question is, and then of course they took it away from them and the government kind of took over with the Affordable Care Act. So the question is, if they get rid of Obamacare, if they get rid of the ACA, who's going to start paying for medical care? Where is the medical care going to come from? And who's going to be, even more important than that, who's going to be in charge? That's the really important part. Who's going to be in charge? We know we can't trust the insurance companies because they're just there for the bucks. We tried the doctors taking care of everything, and they didn't do a bad job. But healthcare costs just skyrocketed. So the government tried to take over, kinda, with the ACA, the Affordable Care Act. At least they gave them parameters as to what to do and how to charge things. So the question is, now that now that they almost got rid of ACA, they keep taking little pieces of it out. Who's going to be in charge, and where's the money going to come from? That's the biggest question. Physicians may fail to listen to patients or treat them like children or medical school faculty. And of course, almost worse than being treated like a little kid is being treated like you know everything. And then they don't give you the information that you need. Oh, you just had a heart attack. You had 97% occlusion. We're going to send you home and take care of yourself. You know, so what do I do? What do I do? What do I do? Do I need to change my diet? Do I need to stop eating salt? What do I need to do next? People are not chosen for medical training on their basis of social skills. As a matter of fact, I swear that I've worked for more doctors with Asperger's syndrome than I've worked for doctors without Asperger's syndrome. God, but I'll tell you, it's just really kind of interesting. Sometimes I'll tell you, people that go to medical school are some of the smartest people around. Unfortunately, intelligence doesn't have anything to do with social skills. This is really kind of fascinating. I was talking to my son on Friday. Was it Friday? No, Thursday night. He said, "Dad, I just went to." He's getting his master's degree in mathematics, experimental mathematics. We're not talking about normal stuff. We're talking about crap that I don't even understand the words for. Anyway, so he says, "Dad, I just came back from a graduation party. There are six members of the faculty. There are 6 people in the faculty at his institution, and so they were celebrating graduation. I don't know, 15 kids or something. But there were 6 faculty members there, and my son's kind of like me, a little bit outgoing, maybe just a tad. He was a bartender, and when you're a bartender, the more outgoing you are, the more tips you get, the better money you make. So he's got that going for him. He's also a bodybuilder, which has got that going for him. He played semi-pro soccer. Nice kid, really good-looking fella. Fairly affable. Doesn't wear glasses. He doesn't wear glasses. He has reading glasses, but he only uses them every once in a while. So he doesn't look like a nerd, okay? Okay, so he's at this party, and all the six professors had to stand up and talk about the graduates, which was kind of interesting. Because 4 of them, he said, "Dad, 4 of the guys wouldn't make eye contact with him." they wouldn't make eye contact. They stood up there and they read what they had to say, and half of them could barely read. I mean, these are math guys, and some of them aren't from the United States. He said, and then the one guy got up there with his computer and he pretended that he was looking on his computer, but I saw it. It was completely blank. He was hiding behind his computer. That's 5. So they've got one guy that can make eye contact, one faculty member that can make eye contact. So social skills, especially with experimental mathematicians, not that important. He was talking about this guy that he lifts weights with. His name is Frank. You know Frank. Don't you know Frank? Frank's funny because Frank talks really loud. He can never get his point across, so he really talks loud. Well, what's that all about? I mean, who does that? Who does that kind of stuff? And then there's a lady in the class, and he says, "Dad, she keeps just blurting things out. You got a booger hanging out of your nose. I don't like the way you did that. Your fingernails are dirty. All this inappropriate stuff." The people have Asperger's syndrome. All these people have Asperger's syndrome. They've got a problem. Well, the smartest people in the world, most of these individuals are able to concentrate on one select thing. And so medical school is the same way. So when we talk about individuals with bedside manner, we're really not talking about these individuals. These people are hoping that they go into research, or maybe they can become do autopsies for a living, so that they don't actually have to talk to people. Strangely enough, medical schools place extremely small emphasis on social skills. I was shocked to find out that medical schools have one class. Most medical schools have one class in pharmaceuticals. One class. So you take one class, you take all these chemistry classes, of course. but you only have one class in pharmaceuticals. So when you're talking about prescribing medications, where do they get their information? Of course, these things are changing on a continual basis. But they only take the one class. So where do they get all their information about the pharmaceuticals that they're going to be prescribing for you? Oh, you seem to have acid reflux, so I think I need to give you something for acid reflux. So where do they get that information? I'm sorry? These guys aren't doing research. You're pretty close to being right, because the place where they get it from the pharmaceutical reps. So these guys will come and visit them and say, hey, we need you to sell this Prilosec. It's the best stuff out on the market, and this is the reason why. Of course, they don't understand what they're saying, because they're talking about chemistry, and they kind of slept through chemistry class. You remember sleeping through chemistry class, okay? No. Anyway, it's really kind of interesting. Providers vary in their attitudes about their own role and the patient's role in consultation. Some healthcare providers have negative perceptions of certain patients. And I've told you some of the negative perceptions that we had. Some people don't like the elderly, even though they get better pay for the Medicare. Patients with low socioeconomic status, even though they get better pay for Medicaid. And some of them don't like minority patients. Maybe they were racist. Maybe they're racist. You run into these people from all the time. And some people don't like to treat women or men, whichever the case may be. I went to a female doctor one time, and she just hated men. It was fairly obvious. She was real short with me, but my sister went to her as well, and my sister said she was wonderful. She spent 15 minutes talking to me. She didn't spend 2 minutes talking to me. She didn't want to hear any of it. There was obviously something wrong with me. And unfortunately, it was probably had something to do with my anatomy, which is a tragedy if you think about it. Mutual participation. Patients today are more assertive. They're better informed consumers. They insist on playing an active role in patient-provider interaction, and that's because we can get information off the internet. As I told you before, I have a heel problem. I could have gone to the doctor and asked him what the hell's going on with my heel, but instead I just looked it up on the internet and went, it's plantar fasciitis. There's nothing he can do about it. What's he going to do? He's going to tell me to do exactly the same thing that I'm going to do myself. So I'm not going to go in and see my doctor. I'll just treat my own plantar fasciitis. Both of my kids have had it. This is like the third time I've had it, so it has never felt this bad, though. Of course, I'm old. I'm really, really old. And as you get older, and we're going to talk about this, as you get older, not this doctor, but as you get older, things start messing up a lot more frequently. Communication skills training is now a fundamental component of medical and nursing education. That's partially true. They try to teach you active listening, where you actually listen to what they say. A lot of times when you're talking to the doctor, he's already decided what your problem is. So no matter what you say, he's already writing it down. That's the reason he's writing things down while you're talking to them. That's not active listening. Active listening is where you actually hear what the other person says. Sometimes you'll look at your records. You remember what you said to the doctor. You'll look at your records, and you'll discover that he didn't write anything down that you were saying. He wrote down what he thought you were going to say. So you have a fever, and you said, I had a fever of 99, and he doesn't write it down because 98.6 is normal, right? Isn't that normal? Okay. My normal temperature is like 96.2. So 99 is like 101 for everybody else. Why doesn't my doctor know that? Because he doesn't listen to what I say. Communication enhancing interventions for patients, assertiveness coaching for the patients. Sometimes they just will not speak up. The internet is becoming a major vehicle for healthcare. Telemedicine, telehealth, is the delivery of medical information and clinical services through interactive audiovisual media. Part of every healthcare provider's training is in telemedicine. And so this is what we're doing now. Once upon a time, we used to take x-rays and we had to develop a film. We don't do that anymore. Now with telehealth, not only do we take the picture and send it to another facility digitally, but they have a radiologist right there who will read it and send it back to us. So in the old days, in order to get a radiologist to look at your x-ray film, you had to take a picture, you had to package it up, and you had to mail it to this guy, and then he mailed it back, and you got a result in about a week. Now it takes only takes a couple hours to get it back. And if it's an emergency, you can get it back almost instantaneously. Because as you're taking the picture, he's looking at it, potentially. That's what's going on. Anyway, that's the way they do MRIs now, that's the way they do CAT scans, and that's the way they do most x-rays. In the United States, more than 36 million people are admitted to hospitals yearly, and many experience problems while in the hospital. The need for efficiency has prompted a one-dimensional, depersonalized view of patients. Healthcare systems represents all activities whose primary purpose is to promote, restore, and maintain health, and that's a definition by the World Health Organization in 2006. In the United States, there is a mix of public and private hospitals. Your hospital, IHS, is a public hospital, but it's only public for you. It's not public for me. I would have to be dying before they would even deign to see me. But even though I've got Medicare and TRICARE, it doesn't make any difference. You know, it seems to me that since we're both on a government plan, that I could just go over there and see the doctor, but it doesn't work that way. Anyway, that's a public, it's a public hospital, but only for you guys. The patient-provider relationship is crucial to effectiveness, and of course that all depends on if you've got a doctor that is personable or not. Hospitalization represents a loss of control and depersonalization, a total institution that takes control of virtually every aspect of your life. If you think you can go to the bathroom whenever you want, you can, unless you're in the hospital, and then they tell you to pee in a cup or collect it in this jug. We need to measure it. Sometimes they'll catheterize you in order to collect all of your urine. Can I get up and go to the bathroom? I have to have a bowel movement. Nope, you're going to have to use a bedpan. We'll try it sometime. Try using a bedpan sometime. Anyway, so you go to sleep at 10 o'clock at night. What happens at 2 o'clock in the morning? They wake you up to give you a sleeping pill to make sure that you sleep the rest of the way through the night. I know, stupid stuff like that. So you're not in charge of anything. If you want a candy bar, forget it. No candy bars for you. You'll eat whatever diet they've given you. And of course it takes 2 days for the doctor. The doctor will write on your chart what kind of food you can have. It takes 2 days for anybody to read it so that you get the right food. So here you are, you're drinking, I don't know, broth and eating Jell-O or something. Anyway, so you don't have any real control, and it's very depersonalizing. The whole idea of waking you up at 2 o'clock in the morning to do your vital signs and give you a sleeping pill just doesn't make a whole lot of sense. Patients are expected to conform to the rules for eating, sleeping, receiving visitors, and making their bodies available for examination and treatment. If they want to take you down to get x-rays, of course you have to go down and get x-rays. My mother was a nurse, and she worked in the hospital for, 50 years. So when she was dying, my poor mother, she refused all this stuff. She told them no. When I was a nurse, we scheduled all this stuff, and we told people when we were going to take their x-rays. It's 3 o'clock in the morning, and they're taking her down for x-rays. And my mother, of course, she's only 4'8" and weighs like 30 pounds or something. Anyway, she's refusing all this stuff. The biggest problem is that people suffer from being treated as a non-person, and that's what she really hated, was the fact that they weren't treating people like people anymore. And that's sometimes you can cure people just by treating them like real human beings. If you talk to them like they've got half a brain, sometimes they will actually say something that is like somebody with a half a brain, which is kind of exciting. Anyway, we learned medicine together. My mother taught me medicine, and I used to cure people just by talking to them. That works. It really does work. If you treat them like humans, then they will respond like humans. Informational control intervention focuses on the procedures and sensations that accompany medical treatment. Cognitive behavioral intervention directs, this is from CBT, from Cognitive Behavioral Therapy, directs patient attention to positive aspects of the procedure rather than feelings of discomfort. And of course, CBT or CBI uses modeling, where you show them the way that they're supposed to react. You guide them through what's going to happen. You tell them what's going to happen. You paint a picture for them, and this is known as guided imagery. Teaching techniques for pain management and speedy recovery. The biggest problem that you have is pain. Pain is a really serious problem. I think I told you that I went to the emergency room when I was home for Christmas. I was home for Christmas. Went to the emergency room. Thought I had an appendicitis. And it hurt. I was in a lot of pain. Of course, I can't take opiates, so they kept wanting to give me morphine, and I kept refusing. And they thought I was being non-adherent, of course. But if they'd given me morphine, it would have been like a waste of a bolus of morphine. And they would have charged me $200 for the shot anyway. But that's not important. HMA would have paid for it eventually. Now here's the funny thing. So as soon as I found out that it wasn't an appendicitis, the pain wasn't nearly as severe. I wasn't worried about it anymore. And since I wasn't worried about it anymore, I went away. Didn't worry about it. I mean, if I've hurt my leg and I think it might be broken, and then I have the X-ray and it's not broken, then I can start walking it, right? I don't have to hop around on it. Right? Isn't that the way it works? So you can actually, your brain can actually fix you if you can visualize what the problem is, what the situation is. I haven't had a problem with my heel all day. I've got these basketball shoes on. I guess it's working pretty well. Anyway, that's what Lamaze training is, CBT training as well. Healthcare needs have changed in rich and poor countries. The expectation of access to care continues to increase. This is one of the things that Doctors Without Borders does. Doctors Without Borders is really a fascinating group of individuals. It's based out of France, and they go all over the world, and they will go wherever people are not getting good health care. And they will live in the community, and they will help them. These are doctors with lots of knowledge. They give you all kinds of basic information. When I found out about Doctors Without Borders, I wanted to go to medical school so that I could do that. But then I realized that, I've been in the military. They're not going to trust me to go anywhere. They'll think I'm a spy. I'll get shot someplace. Anyway, so I figured I couldn't go. But it sounds like a really fascinating, wonderful thing for people to do. Anyway, that has really increased the amount of care all over the world. The demands for measures to protect people from financial cost of poor health. Poor health, of course, this has helped people. Mother Teresa in India was a very similar situation. She was always contracting for people to come and visit and give people health care. I worked for a doctor in Vienna, Virginia. We're going to Fairfax. Vienna's right next door. Wonderful guy. Well, it's kind of a jerk, but a really good doctor, pediatrician, and he went to the Ukraine one year, and that's what he did, health care for about a month. And he paid for it. It was like a vacation as far as he was concerned, except it was a working vacation where he went and worked with the people. He took his own medical supplies, and they were looking at children for ear infections. That was his specialty, otitis media, and that's what he did for a whole month. Paid for everything himself. Just amazing. This trip cost him probably $15,000, but he was giving back. He was giving back to people. Not people that had given him any money, but for people around the world. It's kind of interesting. It was kind of interesting that he went to the Ukraine, because during World War, he's Jewish, He's very Jewish, and during World War II, the people in the Ukraine, a lot of them worked in the concentration camps, the death camps, which was really kind of interesting. I found it very curious. Either he didn't understand his history, which I don't think was the case, or he went someplace that was dangerous for him because he was Jewish. And while he was there, he wore a yarmulke. Well, there are no Jewish people living in the Ukraine. They exterminated them all during World War II. But he went there, and they gave him things. They gave him, I still have a picture that this little girl painted for him because she was so grateful for what he did. Really kind of fascinating. Anyway, so healthcare is getting better around the world. Information on a wide range of topics and issues has been sought. Not everybody is the same. People in Africa aren't the same as people in the Ukraine, as people in the United States. One of the things he discovered was he was working with otitis media. Otitis media has to do with the ear, is an inner ear infection. Some individuals have a long ear canal, some people have a short ear canal. What he discovered was that people in the Ukraine have a short ear canal, and that's one of the reasons why they were suffering from it's a short outer ear canal. So if something gets into their ear, it very readily will get into their inner ear and cause them an infection. Well, there's another group of people around the world that have a very similar ear to that, and that's American Indians. You guys have a short ear canal. For this reason, bottle feeding is sometimes can cause ear infections. That's one of the things he discovered. He wasn't really doing research on this, he just serendipitously discovered it. Anyway, we're getting all kinds of interesting information from all around the world. Healthcare professionals, there are three groups of healthcare professionals. Physicians, of course, MDs and DOs, nurses and nurse practitioners. This is a nurse who has gone to medical school in one specific area. She doesn't have general knowledge about all medicine, just in one specific area. So you'll have a nurse practitioner in OBGYN or pediatrics. And of course, they have the same knowledge base as a doctor does. Then the other is physician's assistant, which is some similar situation with an individual who is not a doctor. They are a PA, but they have a specialty in a specific area. And these are the healthcare professionals. Global healthcare delivery systems, national health services around the world, mandated insurance. Mandated insurance is what we had in the United States until they started dismantling the Affordable Care Act. And the pay-as-you-go care. Pay-as-you-go care has to do with having insurance or not having any insurance and paying for your medical care when you need it. Pluralistic systems, patient-centered health care, delivery of health care services that are respectful of and responsive to individual patient preferences, needs, and values. National Health Service, single provider system. A single provider system is where you have a single doctor that takes care of a group of individuals. It's known as a beaverage system. National level or regional, local level, that's what they have in Canada, that's what they have in the Netherlands, that's what they have in England, that's what they have in Germany. They have a national healthcare system where you probably won't get to see the same doctor over and over again, but you will, all of your healthcare is for free. A number of years ago, they were doing a study looking at the national healthcare in the Netherlands. And what they discovered was that 17% of their gross national product goes into healthcare, but it's all free. So once upon a time, I had an ex-wife that was living in the Netherlands. She couldn't get pregnant. She'd always wanted to get pregnant. She never could. Nobody could get her pregnant. Nobody had been able to get her pregnant. She'd been married, I don't know, 4 or 5 times. So when she was in the Netherlands, she went to see a Dutch physician, and he sent her, all healthcare is free. So he sent her to a specialist, and the specialist said, you've got a problem with your fallopian tubes. And so they went in and did an amniocentesis. what they call it, histosipingiogram. They went in through her belly button, and it was like orthoscopic surgery of your reproductive area. So they stuck a camera down in there, and what they discovered was that her fallopian tubes had adhesed to her colon. So instead of having straight fallopian tubes like everybody has, she had V-shaped fallopian tubes, and where they had adhesed to her colon, they had pinched off. So here she was producing eggs, but none of them were migrating all the way down into her through her fallopian tubes. Not only that, and this was the lucky part, but it was completely shut off, because if it hadn't, then potentially a sperm could have gotten through there. The egg couldn't have escaped, but the sperm, if the sperm could have gotten in there, it could have gotten in there and impregnated an egg, and she would have had an ectopic pregnancy. So they went in and they fixed it. A couple months later, she got pregnant. She was married at the time to number 5 or 6 or whatever it was. I don't know. Anyway, she got pregnant, and because it wasn't completely straight, it got stuck, and she had an ectopic pregnancy and blew out her fallopian tubes, or that fallopian tube, not her other one. Is there a happy story to this? Yes, there is. There is. She divorced that guy. She didn't like him anyway. She divorced that guy, and she stopped having sex with people until she could have a artificial insemination. And then she had a set of twins, so she's happy. The last time I talked to her, she was pretty happy. Anyway, what are we talking about? National Health Services. Mandated insurance, social insurance, compulsory universal coverage through sickness funds paid jointly by employers and employees. And this is, the mandated insurance is the ACA. It's primarily what we have in the United States, or some people have in the United States. If you have a good job and they give you health insurance, then you don't have to worry about it. But if you don't have health insurance, and there were like 18 million people in the United States that weren't being covered by that type of insurance, then the ACA, of course, was something you could buy into. It didn't quite work that way. There were a lot of people that complained about it because it looked like it was working too well or something, I don't know. Anyway, we'll see what happens in the future. Pay-as-you-go care, individual purchase of health care at the time of treatment. And of course, that only works if the health care isn't very expensive. Pluralistic systems, combination of 2 or more of the approaches. Health maintenance organization is where the insurance company controls the health care, and that can work. Blue Cross Blue Shield used to be that way. It's not anymore. Actually, it still is an HMO, but because of the Affordable Care Act, they don't have the same power that they used to have. They used to control everything. They used to control all aspects of healthcare, these HMOs. And if you needed surgery, sometimes they wouldn't approve it. And of course, if it was surgery to save your life, you'd go and do it anyway. And then, of course, you'd have this huge hospital bill to pay. But the HMO made the decision as to whether you were going to have the surgery or not. Managed care preferred provider organization. PPOs and HMOs primarily use this A-select doctor. So if you are going to, if I'm a member of an HMO, I have a choice of 15 doctors in this one town that I can go to. Out of 100 doctors, I have to go to one of those 15. And of course, they're all tied into the insurance system. So a lot of times, they won't approve any expensive medical procedures. That was the biggest problem with HMOs and PPOs. What do people want from their healthcare providers? They want to be treated with dignity and respect. They want them to listen carefully to their concerns and their questions. Not everybody has medical knowledge. We do now. We have access to medical knowledge now, but sometimes you still can't understand it. You know, I studied medicine for, 30 years, and sometimes I don't understand things. Even though, I've argued back and forth with a doctor or talked to the nurses about certain situations, things change over time. New medications come up. When I first started working in medicine, leukemia was a death sentence, especially for kids. So if you had a 3-year-old that developed leukemia, you might as well buy the coffin because the probability that the kid's going to survive is very, very low. But now, of course, we can cure leukemia. When it wasn't more than 5 or 6 years ago that hepatitis C was also a death. You would die with hepatitis C. Now we have a medication that actually treats hepatitis C, which is kind of exciting. So things change over time. When we first discovered AIDS, of course I talked about this in the last chapter. When we first discovered AIDS, there was no treatment for it. We didn't even know what the hell it was. So that was a death sentence. I mean, literally, it was a death sentence. If you had AIDS, you were a goner. And there was nothing we could do. But now, of course, we have treatments for it. So things change over time. We develop medications. We develop new ways of looking at things. If you had a skull fracture, when I first started in medicine, we would take an x-ray, and if we could see it, we could see it. If we couldn't, we couldn't. If you had a brain tumor, there was nothing we could do. We couldn't even visualize it. But now, of course, we have MRIs and CAT scans, so now we can visualize all these things. So what do they want from their healthcare provider? They want somebody that they can talk to. I used to work for the guy in Oklahoma, real affable guy. He would, sometimes his buddies would come in, and by God, they would be back there for an hour. And of course, all the patients are stacking up in all the rooms. But he was easy to talk to if you were a guy. If you were female, he wasn't so easy to talk to. They need to take your concerns seriously, and this guy did, and that's one of the reasons why he was such a good doctor. They need to be willing to spend enough time with the select individuals, and of course this guy would do that. Truly care about them and their health, and he did. He was a member of the community. He knew everybody. He had given birth. He was a doctor that was in charge of all these births, so he knew them from birth to death. So he was a really good guy. Fat. He was really fat. He was overweight. They need to have good medical judgment, and he was a great diagnostician, really good. Ask good questions to understand patient needs. Is he able to ask questions? Not the guy with Asperger's syndrome. Be up to date with research, and this guy was. He was very much up to date with what was going on. And it was because he was obsessive compulsive. He was really kind of an interesting guy, but he was obsessive compulsive, so he read obsessively. And he lost his wife because of that, because he wouldn't pay any attention to her. See them on short notice if needed. Yeah, this guy had all these emergencies. He would make 5-minute emergencies throughout the day. So if somebody came in with a cut on the hand, he'd sew the guy up. He'd clean it out and sew the guy up. So he had this worked into his system. He had 5 minutes out of every hour, and he worked 8 hours a day. So he had 5 minutes out of every hour. He would accumulate these 5 minutes through the day, and if somebody came in at 4 o'clock, then he had an extra, hour that he could spend with this guy, or whatever. Kind of a cool guy. A jerk to work for, but he was really good with the patients. And I appreciated that. He was kind of mean to me, but I didn't really mind because he was so good with the patients. And they would tell. Everybody loved him. Everybody loved him but me, of course. And I would have gone to him in a heartbeat. Accountable Care Organization is an organization of healthcare providers that agrees to be accountable for the quality, cost, and overall care of its members. The Affordable Care Act is expected to bring about changes in the United States healthcare system, how it is paid for, and how it is provided. And it has. They have dictated select things that were going to happen. Once upon a time, an insurance company, if you started with that insurance company, if you had a prior condition, they didn't have to pay for it. So if you have a child that was born with some kind of a birth defect, they wouldn't have to pay for it. The insurance wouldn't have to cover it, and you'd have to cover it yourself. Really kind of an ugly situation. Now that's against the law. The Affordable Care Act won't let them do that anymore. The insurance companies have to cover that. And it has really upset the insurance companies a lot because they have to pay for something that they didn't have to pay for before. Now they're a little bit upset. The core principles of the Affordable Care Act, individual mandates, affordable coverage, of course, is what they were looking for. They didn't get it, but that's what they were looking for. There were employer requirements, and that's one of the reasons why this institution bought into the HMA system, coverage for preventive health services. In the old days, insurance companies wouldn't pay for you just going in and having a checkup. But now they have to pay for at least two checkups a year, and they have to give you and there's a certain rate that they can collect. All these people, and that is the end of that chapter. Oh my. Chapter 13. Three more lectures after today. I know you're as excited as I am. The next chapter is about pain. I was reading about this before I came to class. I was trying to figure out, well, are there any other people that aren't sensitive to opiates? So I looked it up, and what I discovered was that about a third of the people in Norway have some insensitivity to opiates. About a third of the people in Norway. They had this one guy that they hit him with 60 different boluses of morphine, trying to knock him out. Who does that? What idiot does that? Well, these are doctors. They can't believe when something doesn't work the way they want it to work. So they hit him with 60 different shots of morphine. It would have killed a whole herd of horses, let alone, well, I don't know how many horses you have in your herd. Anyway, 60. They gave him 60 times the dosage for a human being. So then they were talking about synergistic effect and enkephalins and whatnot. And what they discovered was about a third of the population of Norway has some degree of insensitivity to opiates. Of course, I've complained about codeine and I've complained about morphine. Doesn't work on me. And of course, doctors are stupid. This is why doctors are so stupid. They don't hear what you say to them. They don't believe you because they think that you're after something else. What is pain? Clinical pain is pain that requires some form of medical treatment. Costs of pain in the United States between 500 and 635 billion dollars a year. This is a big business, controlling pain. About a third of the people in Norway and about a third of the people in the United States have chronic pain. They have pain every day. And I guess I'm lucky I don't. That's equal to about $2,000 per year per person in the United States. So I hope none of the people in here have any chronic pain, but I'm sure there's somebody that does. Prevalence of pain. Pain is experienced by 1/3 of the U.S. population. The most common reason people seek medical treatment is for pain relief. So pain is really, 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 really serious. Acute pain is sharp, stinging pain that is short-lived and usually related to tissue damage, maybe a burn, a fracture, some overused muscle that you pulled. It hurts real bad. Now here's the bizarre thing. I tore my ACL. I don't have an ACL in my left leg, my left knee. It's gone. So when did it leave me? Well, I know when they chopped it out, but when did I tear my ACL? Has anybody ever torn their ACL? Anybody ever? It hurts. Hurts like the devil. You see it. You see somebody playing basketball and they plant and cut and then they tear their ACL and they're screaming in pain and they're grabbing over it. And I'm laughing. Well, I tore my ACL and it didn't hurt me at all. Remember it. How can you not remember something so painful? Recurrent pain are episodes of discomfort interspersed with periods in which the individual is relatively pain-free that recur for more than 3 months. The reality is your body doesn't want to be in pain. Your brain doesn't want to be hurt. It doesn't want to be in pain. So the reality is your body tries to take care of it. And so the pain will go away. You've probably seen a football player who breaks his finger and his finger's sticking all over in a strange angle. And when it first happened, he probably felt it, but all of a sudden it went away. How in the world does the pain go away? I mean, he's got a completely dislocated finger. Shouldn't that hurt like the devil? And the answer is yes, it did hurt for the devil for the first 20 seconds, and then his brain took care of it. Pain has to make its way into your brain in order for it to hurt. So the pain has to be communicated through your spinal column, and then it has to make it all the way up to your brain. But if we can stop that, then you're not going to feel any pain, as odd as that sounds. Chronic pain is a pain that lasts for 6 months or longer, long past the normal healing period. Pain may be continuous or intermittent, moderate or severe, and felt in any part of the body's tissue. This is the problem. Sometimes you have a pain in one place, and it actually originates in another place. And this is a problem that we have with pain, because pain doesn't always tell you where it is. Sometimes it's in a different place. My wife has been complaining about back pain for about 6 years now. And now we find out that it's in her hips. Well, her hips are down here, and her pain is up here. It's in the small of her back. So how does that work? Why did it do that? And it's because pain doesn't always tell you where it is. And that's what has happened to my wife. Hyperalgesia is a condition in which a chronic pain sufferer becomes more sensitive to pain over time. A normal adaptation during sickness, of course, is that you're more sensitive to pain. And that's what hyperalgesia is. It's somebody that is hypersensitive to pain, I guess. Why don't we stop right here, since Tara's leaving, and we'll pick this up next time, right here, when we're talking about pain, and this lovely picture of the severed arm feeling no pain, I guess. I don't know, maybe he is feeling pain. Anyway, I'll talk to you guys later, I guess, whatever. Oh, wait, let's turn this off.